Dr. Shivakumar MC, our next speaker, to deliver a lecture on erroneous pulse oximetry.
Next 15 minutes or so, I'll be speaking on the most common problems arising while monitoring the pulse oximetry. That is erroneous pulse oximetry and how to troubleshoot. Can you display? So we all know that pulse oximetry revolutionized the monitoring of oxygenation. Of course, it's not a ventilation. Of course, it's how to monitor the oxygenation. It is a revolutionized. It is a non-invasive technique. It's a part of ISA minimum mandatory monitoring. So it is whether you are doing a general anesthesia or NORA, it's a mandatory. It's often regarded as a fifth vital sign. So before we understand how to troubleshoot various errors of a pulse oximetry, we have to understand a basic principle. So it based on the Beer-Lambert law. Is simply in a solvent, a solute absorbs a lights differentially. Based on the absorption of these solutes, we can calculate how much amount of the solute is present in a solvent. This is a simple principle. So based on this, we have oxyhemoglobin, deoxyhemoglobin, which absorbs differentially. Oxyhemoglobin absorbs infrared and deoxyhemoglobin absorbs a red light. That's why it's very easy to remember how, if you see arterial blood, how it looks is more bright because it does not absorb a red light. It reflects. So that's why it looks more bright and more red. Deoxyhemoglobin, contrarily, it looks more darker. This is an easy way to remember which light is post-digest is easy way to remember which one is absorbed by which light is absorbed by which hemoglobin. So red light is absorbed by deoxyhemoglobin, infrared is absorbed by oxyhemoglobin. This is a simple thing. So then the principle is there are two light emitting diodes. One is a red and infrared, which will be traversing through the tissue, then absorbed by a diode, photodetector. This is a basic principle. So this identify any hemoglobin, whether it is in the arterial blood or a venous blood. How to differentiate between how to calculate the hemoglobin in the arterial blood only. So this is based on another principle, that is in a cardiac output, amount of a hemoglobin varies in a diastole and a systole. In a diastole, the amount of hemoglobin decreases and it increases during systole. So there is a ratio called amount of the absorption of the red light during the systole divided by absorption of the infrared light during the systole divided by infrared absorption during the diastole and systole and diastole. This ratio is called a modulation ratio or R ratio. So the venous, there will be static, there won't be a change in the volume or amount of the hemoglobin. But in cases of arterial blood, there will be changes. That's why we can, most of the pulse oximetry, we can identify the arterial pulse hemoglobin level based on this principle. Coming to the causes of errors. The causes of intermittent dropouts are inability to read a pulse oximetry. This is the commonest error we encounter during the ICU or OT. Patient either may be hypovolemic or maybe a sepsis patient with hypovolemia, arterial compression, or we have put a pulse sphygmomanometer cuff on the same limb where the pulse oximetry is monitored, or arterial block or peripheral vascular. These are common conditions. Most common cause is hypovolemia, hypothermia. These are some of the conditions which attenuates the signal. So how to troubleshoot in these cases? So problem is you correct what are the primary causes. It takes a time. So you can't immediately correct the blood pressure. Even if you give a vasopressors, what happens? Vasoconstriction increases. Still, you will get a dropouts. One is a low perfusion signal, extremely low, and you have to amplify the signal. So amplification will produce actually a noise. So this noise has to be filtered out. Then amplify both venous and arterial then filter out the venous thing. So this is the principle of newer techniques. The most of the newer pulse oximetry, you say that it works in a, they say it works in a low perfusion, they works in a low perfusion. This is the principle. What is? It also acts as a conventional, then it amplifies the signals, then filter out the noise, then it amplifies only arterial signal. Then this is taken and it will be measured and given. That's why it works in a low perfusion system. Okay, so there are newer, I don't want to name, because the conflict of idea will come. There are so many newer devices have come up. These are second generation SpO2. When you are purchasing for your institute, purchase the newer which works for a, that is the most important thing when you are, especially when you are working in a ICU. Okay, so while clinical assessment can help to differentiate spurious from the true SpO2. One is you can warm the patient. Of course, that's still it doesn't work sometimes, most of the times. Changing to a different finger. Suppose you have prolongedly put in the same finger, you change it to a different finger. Sometimes what happens, especially postgraduate, they'll tape the pulse oximeter. Don't tape it. If you tape it, definitely the venous pulsation will start coming and spuriously shows the low. And you change it to sphygmomanometric cuff, you change it. Certainly, cases should be sometimes corroborated with the arterial blood, especially in ICU, corroborate with the arterial blood gas. And most importantly, use newer techniques. Second, causes of falsely normal or elevated SpO2. Most common is carbon monoxide poisoning. What happens in carbon monoxide poisoning? The possibility of CO poisoning should be clinically, you can identify clinically. Patient normal pulse oximetry with patient is critically ill. This is as simple. If the normal pulse oximeter reading patient is very ill, you should first, and the history suggesting suppose fire accident is there or patient is a closed smoking inhalations, you always suspect carbon monoxide poisoning. This is as simple as that. You always suspect that. So, basic principle one, you should understand, oxyhemoglobin and carboxyhemoglobin absorbs a red light. You have seen carboxyhemoglobin, it also looks very bright, even more brighter than the PaO2 of 360. So, even more brighter than the oxyhemoglobin, because they absorbs 660 nanometer, that is, they don't, similarly they absorb less red light, but you see that near infrared light is minimally absorbed in carbon monoxide poisoning. Almost you can see that minimally absorbed in a carbon monoxide. That's why it looks more bright. So how to differentiate? One is already I told history. Is a patient with a normal pulse oximetry with a very critically ill patient, then definitely. But one thing, even arterial blood if you take, SaO2 looks normal. Because SaO2 calculates what? Oxyhemoglobin divided by oxyhemoglobin plus deoxyhemoglobin. It does not consider carboxyhemoglobin. That's why it will be normal. So don't get confused with that. But if you have a co-oximetry, fractional oxyhemoglobin content has to be calculated. It will be lower. Because fractional oxyhemoglobin, the oxyhemoglobin divided by oxyhemoglobin, deoxyhemoglobin, and other methemoglobin and carboxyhemoglobin. So it will be lower. If you normal conventional arterial blood, SaO2 will be normal. Consider normal SaO2, decreased PaO2, decreased fractional oxyhemoglobin in a co-oximetry. And most importantly, if you have one is history and use the co-oximetry if you need. Mainly you can diagnose by the history. Cause of falsely low SpO2, definitely venous pulsations, excessive movement, these are one most common problems. Intravenous pigment, of course, is a less common. Inherited and abnormal hemoglobin, fingernail polish, and severe anemia. I'll just, important points I'll tell. So venous pulsations, when it occurs, suppose you put a adhesive plasters tightly around the finger, severe tricuspid regurgitation, and when the location of the probe is very dependent, tendinal position with a forehead SpO2 probe is there, then chances of venous pulsation will be there. And in most, in a possibly in a distributive shock, like a septic shock, there may be chance of venous shunting and venous pulsation may occur. So this leads to a lower uh, uh, pulse oximetry, lower level of SpO2. You can just identify based on the history how to troubleshoot. You change the probe position. If the plaster is put around the finger, you change it. So simple maneuvers will change the most of the things. So coming to excessive movement, this is the other most common this thing, especially in a spinal anesthesia have given, there is shivering or a patient is moving. These are some of the artifacts which occurs, which invariably produces a lower SpO2. Because of movement, it will detect that even venous blood will be detected as arterial blood because of movement. So that's why it will, the SpO2 comes down. So what are the newer technology? They filter out these noises. These movements will be filtered out. Then all the artifacts will be filtered. Then there are an algorithm to filter all, to reduce this occurrence of false SpO2 reading due to excessive patient movement. Then these patients, forehead probes are definitely helpful. So in this condition, newer probes are better, of course. Coming to intravenous pigments, I've used a methylene blue during COVID and a severe septic shock we have used. So what happens, I have seen, suddenly SpO2 drops to a 60, 65. The maximum it goes down to 65 because absorption, you have seen that absorption of a red light almost 668 is this thing, methylene blue. That's why it will go down to SpO2 low. This how to troubleshoot if you know that patient you are giving a dye, you should not be panic if the SpO2 goes down. Patient will be all right. So I have seen in a COVID patient, you inject methylene blue, it will go down to a 65, patient will be all right, or it will not be deteriorated. Okay. Other dyes usually does not affect much. Even iodocyanine and indigo carmine, they don't affect much. So you need not worry about those. So coming to fingernail polish, this is a common thing. Of course, in a older pulse oximetry, there will be, especially black, blue and green color will lower the SpO2 by 10% because of absorption of a light. But newer models of pulse oximeters, the fingernail has minor effect on the SpO2. So especially black and brown will reduce only by 2%. So need not worry. Only thing is, if you are using a conventional, you remove the pulse oximetry while monitoring. That is the thing. Coming to anemia, what is the effect of anemia on pulse oximetry reading? So SpO2 underestimate SaO2 in a patient with the hypoxia with anemia. If the patient is hypoxia with anemia, it underestimates the SaO2. SpO2 underestimates. But has a little effect on the SpO2 measurement during the normoxic patients with anemia. This is because in anemia patient, based on what is Baer-Lambert principle, they think that light goes straight. It will not work like that. The light will be, there will be a reflection, there will be deviations. So in anemia, there will be more reflections or scattering of the lights will occur. So that's why the SpO2 will be underestimated during the anemia, especially in a hypoxic patient. But it is better. If you underestimate, you will be giving oxygen earlier than you are supposed to give. Then anemia, if your oxygen content is already low, it is underestimating, you are giving oxygen earlier, so it means that it is beneficial. You need not worry about that. So if you really want to know what is the oxygen content, do a ABG, if you really want to know. Otherwise, it usually underestimate, it's a better for monitoring. You will give oxygen earlier, oxygen content will increases. Falsely low or high methemoglobin, we know that methemoglobin absorbs more infrared than either oxyhemoglobin and deoxyhemoglobin. Since its absorption of red light is similar to the deoxyhemoglobin, patients with significant methemoglobin can be cyanotic and their blood will be very dark. And methemoglobin absorbs both red and infrared equally. So modulation ratio, that is, I already mentioned modulation ratio reaches 1. That's why, so it will be almost SpO2 reaches 85% in case of methemoglobin. So what is the how to this thing? You know the history, whether any dyes have been this thing taken or usually aniline dyes, all those things will be. You take the history, methemoglobin can be directly analyzed by coaximeter on 50 seconds. Coaximeter, arterial blood gases and coaximetry you can measure. Usually 85% you take the history and directly analyze by a coaximeters. Or take the arterial blood measurements. Sulfhemoglobin is similar to methemoglobin. And the other most important thing is, Methemoglobinemia, you give a methylene blow, immediately it will be corrected. That's the most important thing. So coming to a sulfhemoglobinemia, it is similar to that is, the irreversible oxidation occurs. So that's why it is an irreversible oxidation occurs. Even if you give a SpO2 will be 85%. So even if you give a methylene blow, it will not be corrected. It's as simple. So methemoglobinemia, it will be corrected. Sulfhemoglobinemia, it will not be corrected. So you can differentiate both of them. Poor propositioning. Suppose in case of ambient light, what happens? Because directly ambient light hitting on the light, it will be, when you suppose especially LED light, so there will be 10 seconds, there will be a direct, it will be unreliable. SpO2 monitor will be unreliable, especially in older devices. So cover the fingers. The second is, newer machines will filter out the ambient light. So you need not worry about it. To summarize, pulse oximetry is based on the principle that oxyhemoglobin and infrared deoxyhemoglobin absorbs lights in differentially. Since the pulse oximetries are calibrated between 70 to 100%, so deviation, if it is less than 70%, it's very unreliable. Newer models are more accurate. Most of the erroneous pulse oximetry can be ruled out in the newer models. History, clinical examination, and appropriate site selection eliminates false alarms. Use co-oximetry whenever is required. Whenever you need, suppose dyshemoglobin, use the co-oximetry. Even in the most optimal patient pulse oximetry interface and setting, completely normal SpO2 does not indicate normal ventilation. Pulse oximetry indicates oxygenation. Thank you all.